Yeah, we're counting down to liftoff, so grab your toast and get ready to spread a little jam on it because it's time to join us for our episode 159 of the Crisis Jam Learning Community. My name is John Draper. I'm the president of Research and Development at Behavioral Health Link, and I am delighted to be with you all today. We're featuring Dr. Maureen Boyle, who's the Chief Quality and Science Officer at American Society for Addiction Medicine. Which we're going to be calling it ASAM today for short. They're located in Washington, D.C., and as we know, 988 has expanded its focus to include all behavioral health crises, and we have not given the kind of attention to substance use disorders as we probably should. We're doing that today. So here we are, 2024. We're kicking it off with a really important substance use presentation. I want you to feel free to visit Crisis Jam's learning community site. We can get all the latest information and buzz around the crisis services community, as well as register for the newsletter. And I hate to miss a Crisis Jam, but I know exactly where to go if I do. That's right here on the Jam site, where I can see last week's incredible debate. I don't know if you all saw that with Jen Stuber and Sabrina Taylor. There was quite a queue trying to get in. So if you missed it, please check it out. You can find other news, updates, and resources from the world of crisis services that you might have missed on this site. And Maureen Boyle will be joining the growing list of Crisis Jam presenters since 2020, now numbering over 400 unique presenters, offering a diversity of perspectives on crisis care. So please let us know if you have a topic we need to hear about and a presenter we need to hear from. A lot of crisis services in the news. Here's a news update about a bipartisan bill introduced by Nevada Senator Catherine Cortez Masto, along with Texas Senator John Cornyn, to expand Medicare payment rates for mobile crisis. So needed. And as always, Senator Cortez Masto continues her outstanding support of expanding crisis services in this country. This is an article from December on MSNBC that was written by Jill Harkavy-Friedman, AFSP, looking at the first year of 988. Be sure to check that one out. You know, coming soon, the National Institute of Mental Health is going to have on their second day, February 12th, a big feature on crisis services. You'll see a lot of names there you recognize from Crisis Jam. Actually, Matt Goldman, I think, is also going to be featured there, but you see Braden Wilcox from Rocky Mountain Crisis Services and Margie Balfour. Again, a lot of folks, Dr. Chuck Browning, a lot of folks that we'll look forward to hearing from on Crisis Jam. But if you can make it to the NIMH Summit, do so. I don't know if any of you have seen this incredible crisiscrowd.org site survey that came up. I thought this was pretty stunning. It's amplifying the voices of crisis hotline workers. It was written by Dan Fichter. This is his brainchild. He's an ex-Trevor Project counselor. And Dan sampled about 50 counselors to find out what they had to say about how we can better support them. And if we expect them to listen to our callers, then I suppose we also really need to listen to them. I am so excited about this. I'm going to be joining some very esteemed leaders with lived experience of suicidality in Salt Lake City this Friday. And we're going to be viewing the world premiere of the Moving America's Soul on suicide. This documentary film is going to feature some really powerful, inspiring stories of folks who sought help and found hope on their journeys towards healing from some really seriously suicidal moments. It's going to be hosted by the Huntsman Mental Health Institute, their foundation, which is it's going to be held here at their amazing Cancer Institute. You can see that this is an outstanding facility. I think they raised over $1 billion for this facility, and I think it's gone so far in improving cancer care and research. We're hoping they can do the same thing for crisis services and mental health care. Turning to our hot seat here, speaking of events that are coming, We're looking forward to a big international gathering I was mentioning earlier of crisis leaders at the Global Leadership Exchange and Crisis Now 3 in June. And Arkin is the European partner for Crisis Now 3. It's the Global Leadership Exchange match. It's going to be held in Amsterdam at the Edge, which is Deloitte's Netherlands headquarters. Arkin has shared that they participate in a weekly interdisciplinary meeting known as Crisisketen Overleg. And this is a little bit more detail on the Crisis Now 3 summit that's going to be occurring in Amsterdam. And you can see the definitions of first responder on the medical side and the law enforcement side. But we know that the first responder for mental health services is going to be a critical area of discussion for the Crisis 3 Summit, and how that's done in other countries is going to teach us a great deal. And speaking of teaching us a great deal, Dr. Richard McKeon has been a leader in crisis care for so many years. It's always great to see you, Dr. McKeon. You are a good friend of Crisis Jam and a good friend of mine. I'm so glad to see you here, and you're one of the few people who can really make that hot seat cool. Richard, are you there? Richard, have you made it on yet? If not, we're going to have to answer this question without you. Well, let's take a look at what the question is. What is the English equivalent of the key word referenced in Crisisketen Overleg? Richard, are you there for us? All right. Am I going to have to do this? Well, let's see if we can get some votes from the audience. Maybe the audience can help us on this. Richard is logging on now. I think he's going to be joining us in just a moment. In the meantime, you all can be voting because our choices are A, assembly, B, chain, C, nexus, and D, partners. So what is keten mean? Richard, are you there yet?
Yes, I'm here.
Ah, you're there. So great, glad to hear from you, Richard. We were having a crisis without you, so I'm so glad that you joined and rescued us from this trivia hot seat. You really were. I was saying that you keep the hot seat cool. Now it's hot because you're on it.
Yeah.
So here's what we're trying to answer is this question. What is the English equivalent of the key word referenced in Crisisketen Overleg? So tell me, what do you think keten refers to? Is it A, assembly, B, chain, C, nexus, or D, partners? And we can see what the audience wants. Now, you can't phone any of your Dutch partners on this one, Richard, but you can certainly phone a friend if you like.
Can I phone someone who was on the run of show who would already know the answer?
Oh, see, I think that's cheating, just like everybody else right now is cheating. I think they are all Googling. I hear the sound of Googling. Please back away from your browsers.
I am not Googling.
All right,
But
okay.
do I get to see what the audience thought?
Oh, here we go. A lot of people think it's partners, Richard.
A lot of
and
people think it's partners. Well,
chain is next. What do you think?
Well, it's actually not in the Netherlands, but in Norway, they pioneered an approach called the chain of care, which was really working on trying to have continuity and follow-up. I do not know whether that might have spread or not, but I'm going to go with B, chain.
Chain it is. And yes, indeed. God, there you are, the cool man on the hot seat again. Richard McKeon, you are so right. And
well, it's all because I'm wearing a Crisis Jam t-shirt underneath my dress shirt.
As we all are, yes. Very good, Richard. Appreciate that. And I wonder, do you know what overleg means?
I do not.
I looked it up. It's the opposite of underarm.
Oh,
No, actually, it means consultation. So this means crisis chain consultation, which is exactly, I think, what needs to be happening throughout our crisis care continuum, is we need to be working together, listening to each other. Richard, thank you so much for joining us today. It's always good to see you, and I'll see you this weekend.
and I'll be back on the jam later for the SAMHSA report.
Oh, you will. You'll be SAMHSA reporting in just a little bit. Look forward to seeing you in just a minute.
Okay.
All right. So as we were looking at the trivia hot seat and thinking about our feature presentation, we were looking back in the annals of our past substance use chronicles and crisis talk. And Stephanie found this quote, which is really an important one, where Rebecca Boss was noting there's a real opportunity at that moment for a person to see hope, and providers are welcoming, engaging, recovery-oriented, non-judgmental, and meet people where they are. And we've got to be able to do that for people in all kinds of crises. And we have not given the kind of time and attention to people in substance use crises. So to help us meet people where they are and find out what's the best fit care for them, we're going to listen to Dr. Maureen Boyle talk about the ASAM criteria that's going to help us determine the right fit for folks. Maureen, you want to go ahead?
Yes. Hi, everyone. And thank you for inviting me today. I'm really excited to be here. I just wanted to, in case I end up coughing, I have a bit of a cold, but I've got cough drops in front of me if needed. So just apologize in advance if there's an interruption. So today we're just going to talk a little bit about how we have updated the expectations for co-occurring care within the 4th edition of the ASAM criteria. And the ASAM criteria, the 4th edition was released just a couple of months ago. The criteria they've become, over the last decade or so, the most widely used and comprehensive set of guidelines for making level of care recommendations and also determining when patients should move to a more or a less intensive level of care. And this is intended to, to be like a level of care placement tool for individuals with substance use disorder, but it also considers co-occurring conditions. And one of the reasons why it's so important is that more than half of states are currently utilizing the ASAM criteria as the foundation of their 1115 waivers for the IMD exclusion. The ASAM criteria are also being used right now as the medical necessity criteria, covering more than 200 million covered lives. So that's most of the people in the country. And the ASAM criteria are used as the level of care standards for licensing addiction treatment programs. And so we really hope that by updating the standards and especially promoting more co-occurring care through those standards, that we can shift the field and how it addresses the need for co-occurring care. So the criteria were first published in 1991, one of the main goals of the criteria is to promote individualized care that considers the wide range of concerns that can impact a patient's treatment and recovery needs. So that's the biological issues, the psychological issues, the social and the cultural. We also say that the ASAM criteria, one of the important features is that it creates a shared language across the treatment system. So it helps the SUD clinicians communicate effectively with the mental health clinicians, as well as with the payers and with state regulators and others, with the goal that everyone is supporting the patient to access the right level of care at the right time, considering their substance use disorders, as well as their co-occurring physical and mental health conditions. Next slide. So how does this all fit into the crisis services, which are being expanded across the country? So the crisis services, as you all know, are serving individuals with substance use disorder, with mental health concerns, and many who have both. And a significant challenge that crisis services may face is determining whether a patient may be best served by the addiction treatment system or by the mental health treatment system. Next slide. So obviously some individuals are going to be appropriately treated in one versus the other. So those with substance use disorder or who may be best treated by the SUD treatment system are those, one, who are seeking substance use disorder treatment. So, patients obviously have agency in this, and some may want SUD treatment. And for others, it may be that the SUD really is their most significant primary concern. For others, they may be more appropriately treated in the mental health treatment system, and that's, again, those who are seeking mental health treatment services, as well as those who have more significant mental health concerns. So when the treatment system, determining which treatment system is most appropriate, the ASAM criteria can guide the level of care determination when SUD treatment is indicated. And I should note that if mental health treatment is most appropriate, then you're really going to use the level of care utilization system. So the LOCUS is the commensurate system for determining the mental health level of care. And we know, so, ASAM understands, as well as our partners in the mental health treatment system, we understand that it can be really difficult in a crisis to determine which treatment system is appropriate. ASAM and the American Association of Community Psychiatry, so it's the developers of the LOCUS, we're planning on working together to develop guidance on this. So when to use the ASAM criteria versus when to use the LOCUS. And I should note that AACP worked closely with us as we were developing the fourth edition of the ASAM criteria, and we're also working with our adolescent mental health treatment system partners to develop the ASAM criteria adolescent standards. And so after our adolescent work is done, we plan on kind of shifting our focus to how do we help the system decide which path to go down, the ASAM criteria path or the LOCUS path. Next slide. So this is just a kind of an overview of the ASAM criteria standards. So we think of them as having three core components that all work in tandem to help determine the right placement for an individual patient. So there's standards for assessment. There's also decision rules for, based on that assessment, determining where that individual patient would be best served along the continuum of care. And that the way that these all work together is that, as the patient enters treatment, a level of care assessment is used. The dimensional admission criteria are applied to make a recommendation for an appropriate level of care. And then, as the patient is in care, they're reassessed regularly to determine, whether they should stay at the current level, whether they should move to a more intensive level of care, or whether they may be ready for a less intensive level of care. Next slide. So the fourth edition of the ASAM criteria follows the same guiding principles that have been the foundation of the ASAM criteria since its inception, which is really promoting a biopsychosocial model of care where admission into treatment is based on that patient's multidimensional needs, that kind of all of the factors that contribute to their addiction as well as their recovery. Patient treatment plans should be individualized based on multidimensional assessments. Patient care should be interdisciplinary, evidence-based, and patient-centered. And that the ASAM criteria also emphasize that most patients with substance use disorder have co-occurring conditions. And that's, and so as a result of that, we've built as a foundation of the fourth edition of the ASAM criteria that all programs should be at minimum co-occurring capable. Next slide. So this is just an overview of the assessment dimensions for the ASAM criteria. So we have 6 dimensions, with the first being intoxication, withdrawal, and addiction medication needs. There's biomedical conditions, psychiatric and cognitive conditions, the substance use related risks, the recovery environment interactions, which looks at both the patient's environment as well as their ability to function within it. And then we have a dimension 6, or a new dimension 6, that's called person-centered considerations. And this looks at barriers to care, patient preferences, and the need for motivational enhancement services. So those of you who are familiar with the third edition of the ASAM criteria may notice that we no longer have a separate dimension for readiness to change. And we absolutely believe that readiness is an important factor in treatment, but it doesn't independently contribute to the level of care recommendation. It's something that's considered within the determination of risk within any of these other subdimensions, right? So, a patient may have a very different readiness to change for their substance use issues versus their mental health issues. Something else to note is that, so in the fourth edition of the ASAM criteria, we've broken down each dimension into actionable subdimensions. So for dimension 3, that includes active psychiatric symptoms, persistent disability, cognitive functioning, trauma-related needs, and psychiatric and cognitive history. And some of these dimensions are used to make a level of care recommendation. So specifically for dimension 3, it's the active psychiatric symptoms and the persistent disability may impact the level of care recommendation. And all of these subdimensions are going to be considered when developing an appropriate and individualized treatment plan. Next slide. And this is a snapshot of the continuum of care for specialty addiction treatment. So there's 4 broad treatment levels, 1 through 4, and within that, the decimal numbers indicate gradations in the intensity and the types of care that are provided. So one of the main focuses of the update to the 4th edition was making sure that we were promoting integrated care. So the column on your right, which has the 0.7 and level 4 levels of care, provide medically managed care. And so these are the programs that are going to be addressing intoxication, withdrawal, initiation and titration of medications for addiction, as well as initiation and titration of medications for psychiatric needs when it's needed. And as I mentioned before, every level of care is going to be expected to be at least co-occurring capable. But the ASAM criteria also defines standards for co-occurring enhanced levels of care. So each of the levels at the 0.5 and the 0.7 level have standards articulated for what it would mean to achieve co-occurring enhanced care. And that's meant to treat patients who have more severe psychiatric concerns, as well as those who need a higher level of staff support to help them manage their psychiatric or cognitive disabilities. Next slide. So the 4th edition of the ASAM criteria defines a level of co-occurring capability, as I said, that all levels of care should be able to provide. And this includes that the treatment plan should be integrated, right? Whether the patient is receiving mental health care from that program or from an external provider, that care should be coordinated and the treatment plan should be integrated. That every program should have at least one staff member who has the training and expertise to be able to assess for mental health needs and to triage those needs, whether that means calling in crisis services or transferring the patient to a co-occurring enhanced level of care, referring them to external treatment, or providing the level of treatment that individual program is able to provide. So standard treatment programs, one of the things we tried to emphasize in this volume is that these standard co-occurring treatment, co-occurring capable treatment programs, they shouldn't expect that everyone with co-occurring conditions is stable and asymptomatic. Patients can be appropriately treated that have mild to moderate acuity, instability, and functional impairment. And it's only really when you get to that level of, needing integrated psychiatric care, needing integrated skilled mental health interventions, and/or, needing a higher staff to patient ratio to kind of manage the instability, where a patient would end up needing a co-occurring enhanced level. So next slide. So this just is an overview of some of the key elements of co-occurring capability that include providing a welcoming environment for patients with co-occurring conditions, with a culture that's supportive of recovery from both SUD as well as mental health concerns, where every patient is screened for mental health issues, and assessed when mental health concerns are identified, that these programs are coordinating care with mental health treatment providers and doing integrated treatment plans, that we're incorporating mental health content into standard programming that includes education around, when, what mental health concerns, interventions are available, and teaching patients with mental health symptoms how to manage those symptoms and how to work effectively with mental health care providers, as well as, or including the psychiatric medication prescribers. And inherent is the ability of all programs to effectively coordinate care with crisis services. Next slide. So as I mentioned, so separate standards are defined for co-occurring enhanced, or what we call COE levels of care. And that's for the levels, the 1.5, 2.5, 2.7, 3.5, and 3.7. And these programs are routinely serving patients with serious co-occurring psychiatric and cognitive conditions. They're providing psychiatric management or oversight, as well as skilled mental health interventions. They have a higher staff-to-patient ratio that allow them to provide more individualized support and respond to instability. And they have formal relationships with mental health treatment programs, because a patient coming out of a co-occurring enhanced level of care, may be most appropriately treated in the SUD treatment system, or they could be most appropriately treated in the mental health treatment system. So they need to have relationships with both systems to be able to appropriately transition the patient to the next level of care. And I would just note that the reason that we don't include co-occurring enhanced standards for ASAM's 2.1 and 3.1, which is our clinically managed levels of care, is that they don't have a medical director. And so for the level of acuity of mental health concerns that require co-occurring enhanced care, it was felt that you need medical oversight for that. And so that's why there's not co-occurring enhanced at every single ASAM criteria level of care. And so we would love to talk about this, and we have with us today, we have Ken Minkoff and Angela Kalistra, who helped to write the co-occurring enhanced chapter of the 4th edition. They also helped define the dimensional admission criteria for kind of those decision rules about determining the right level of care for co-occurring conditions, and defining what co-occurring capable and co-occurring enhanced means.
So I'm supposed to go next, right, Maureen? Should I just jump in,
Ken,
everybody?
Go ahead.
Yeah,
go ahead,
thanks,
Ken,
John.
Just jump on in.
Yeah, so hi, I'm Ken Minkoff, and first of all, I want everybody to give a collective shout out to Maureen, because she was amazing at herding all the cats to get us to put this together. It was really a heroic effort. And as someone who's been working on and advocating for co-occurring capable services for decades, I think this concept was first introduced in like 1987. The 4th edition represents a significant leap forward for the addiction field in terms of recognizing the expectation of co-occurring mental health conditions and creating the expectation that co-occurring capable services for addiction programs is an expectation as well. What I want to talk about is kind of how you might want to be thinking about this from the perspective of being a crisis provider. So one of the things, and Maureen mentioned this, is people commonly show up in any kind of crisis setting, mobile crisis, crisis center, urgent care, walk-in, everything, with various combinations of mental health and substance issues in the crisis setting. And it's important to recognize that just because people present with substance use going on and substance use contributing to their difficulties doesn't mean they're interested in anything resembling substance use disorder treatment. So the ASAM criteria are there for you when you have people who have that particular interest. And I'll talk in a minute about the other group of people. So if you have someone who's both intoxicated and suicidal, for example, and they're expressing an interest in getting help for their substance use disorder in an addiction program setting, then what are the implications of these new criteria? So what is being said by ASAM is it's no longer like you can't, as a substance use disorder program, say simply because the person has suicidal ideation of some sort doesn't mean you should just turn them down. And suicidal ideation, as you all know, exists on a continuum of severity and difficulty. And, for most addiction programs, the expectation that ASAM is laying out is that you should be able to welcome people who have some level of suicidal thinking and help them and engage them and work with them to stay safe and to begin to build hope and address their substance use and whatever other mental health issues they may have in recovery. And that's going to, obviously the person needs to be able to be safe in that setting in order to do that. But now, the direction is that the addiction program will take those people. However, just because ASAM issues the fourth criteria, the fourth edition, doesn't mean that every addiction program is automatically going to be there. So what ASAM is launching is a process of change over time. There are many addiction programs that are already there, but many that are not. And so, don't be expecting that because these are out, that suddenly everybody that you work with is already there. So one of the things to think about is how can you be helpful to your addiction program partners? And this is one of the things that to think about, because many crisis programs and many systems, don't necessarily regard the addiction programs in their community as customers of mental health crisis services. And so what the ASAM criteria are now indicating is they should be. So you should think about that. And secondly, the more that you support your addiction program, the more comfortable they're going to be feeling taking risks with people that you may want to send them. It's like a front door, back door issue. So if you send somebody who may have some suicidal ideas, who seems like they can be safe in the moment, but you're also saying, don't worry, if they get worse, we'll send our mobile team right out there to your addiction program to help you and help them and evaluate them and help them stay safe, including helping them stay safe there, then they're more likely to take that risk on the front end. And the same thing is true with somebody who may be using meth and have some level of paranoia, but they're not like out of control with it. Same deal. So begin to build those partnerships. And on the flip side, yeah.
Just wanted to know, we'll need to turn to Angela in just a moment, but go ahead and finish what you were just about to say.
No, and the other thing that I was going to finish is go back to remember that for many of the folks who present with both issues, we need to be, how do we engage folks who are not going to substance treatment and consider them as a priority for crisis help? So I'm intoxicated, I'm suicidal, but I have no interest in getting sober. I don't want substance treatment. And in the moment, I'm at risk, right? And so there's a whole other piece of conversation that hopefully this will launch on the mental health side about how to develop an appropriate set of co-occurring capability criteria for mental health crisis, for mental health units, for mental health crisis programs, so that they can welcome and engage people who have active substance use issues, who are requesting or requiring mental health care. And I'll just stop with that and hand it to Angela.
Thank you, Ken. Go ahead, Angela.
Awesome. Thanks so much, everyone. I'm Dr. Angela Callistra. And I really, just to add on to what Ken was saying, I think for like decades, we have come from the point of view that this is what we do and that's what you do. Go over there and get that care and we'll take care of our care. And doesn't actually play out in the systems that we're all part of. Like, it's very nuanced, and it's nuanced for us as providers, but it's much more nuanced for the people we're serving and our families and our friends. Like, if you've been a part of that care continuum and you're an expert in the field, it's still very nuanced. But what I want you all to consider, and which is the work that I do every day with ASAM and in the healthcare network that I work in, is training interdisciplinary providers to think about the skills that they already have that are transferable in the space, so you can feel comfortable, confident, and competent in pulling up a chair next to patients as they share substance use disorders and mental health conditions. And don't feel like because you're engaging, it's all on you. But as you orient to your community locally, nationally, or the resources and the mental health and the substance use disorder communities, you begin to understand that you are not alone and that you have these brief intervention skills that are uber powerful in moving somebody's motivation, right? That they're already there in your crisis work, right? And so that is what I want people to kind of bring to the table, because if a patient is disclosing to you on a crisis line their substance use disorder, you've done something right, because it's very unsafe for the population we serve to disclose their active addiction. And so if that is actually happening, the work that you are doing is uber powerful in their life already. So how do you feel comfortable, confident, and competent to step into that, and then pull together these resources within your community? So I think that is what this chapter is getting at. That's what we're moving to. And it's going to take us some time, but I think us as care providers desperately want that. And so I think we just, through that work, we can work on our stigma, our own internal and external stigmas, and all the policies that kind of are stacked up against us that make us afraid. But with the support of community like this, that we can step into that work together and continue to help people heal, which we're all doing anyway. So thank you so much.
Angela, Ken, Maureen, thank you for a very insightful and important conversation. Before we turn to SIMSA updates, just to have a couple of questions for you all, or a question. First of all, I'm just so delighted to hear that beyond baking into the language of behavioral health the notion of substance use and mental health issues, that we're starting to now bake it into our services and our thinking about crisis care. And really, crisis care gives us an opportunity to further de-silo and integrate behavioral health into what it's supposed to be, between substance use and co-occurring mental health disorders. I'm wondering, when we put together the Suicide Prevention Lifeline standards for assessment, we had prompt questions that every counselor was supposed to ask before they did a deeper assessment. And what those two questions are now, something along the lines of have you been thinking about suicide recently, and have you taken any recent actions, including today, to harm yourself? If we were to also include standards, prompt questions that every crisis counselor for 988 should be asking, what would any of you all recommend one or two questions that everybody should be asked? Maureen, what are your thoughts on that?
I mean, I think it probably makes sense to ask if they've recently taken substance, if they're intoxicated or under the influence of substances. I think that that may be an important.
So there's one question would be, have you taken any actions that, have you been ingesting substance use? So that's kind of a corollary to the lifeline. Have you taken any actions to harm yourself? What about the ideation thing, or do you use substances at all? Is that something that you would also suggest that we ask every person who calls 988?
I mean, this may not be an evidence space, but I think could be worth considering, asking, are you at risk of overdose, or, especially this might be more like, if somebody's coming in, like are you at risk for withdrawal, right? Like I think patients typically know, and that could be a way of preparing the facility for, for addressing that.
Yes, and these are risk assessments. So we do want to, beyond the sense of just getting what the sense of what the problem is, what is posing a risk to you right now. And certainly overdose is one of those areas you want to be very sensitive to. Maureen, thank you for a very, very insightful conversation. Thank you and your crew for working on the ASAM criteria. What a tremendous contribution this is to behavioral health. Thank you all for joining us today. We're going to turn to the SAMHSA update. Dr. Richard McKeon, we got to see you earlier, and we just love to welcome you back. So come on, tell us about what's happening from SAMHSA's perspective with your 988 shirt on.
Yep. Thank you, John. Three things that I'd like to mention. One is on the topic of 988 and equity. There's a 988 quarterly equity webinar series. And in fact, the first one in that series, which is entitled Embedding Equity in 988 Crisis Systems, is today from 1 to 3 p.m. Eastern Time. The remaining webinars will be in April, July, and October of this year. Also related to equity in 988, a 988 Equity Learning Collaborative is in the process of being organized. It will take place between February 28th and May 23rd of this year. And there's an application deadline of February 7th. So to get more information, you can go to the SAMHSA website, to the 988 page, and click on the Crisis TTAC, who is sponsoring the these events. Secondly, wanted to make sure people were aware of the Crisis Systems Design Policy Academy that SAMHSA is sponsoring. It'll be taking place in Tucson right at the end of March, beginning of April. Particularly important to bring to your attention because today is the deadline for applications. These are for states, territories, or tribes to participate. And then finally, what I would like to let folks know is to give them a heads up that the National Emergency Number Association voluntary standards on 988 and 911 collaboration will be coming back out. They're not out yet for public comment. So these were out for public comment before, and a group has been working to take into account all of the comments and to make decisions about them. And the second public comment period will be an explanation and asking for further comments on the areas in terms of what the internal work group recommended. And then after that, at some point later this year, these standards should be coming out. Very important, I think, for all of our 988 crisis centers, as well as all of the 911 public safety answering points. So we will keep people alert to that, let folks know on the jam when they are available for this second round of public comment. So that's it for me. Thanks, John.
Really exciting, Richard. I'm so glad to hear that there's not only recommendations coming out, but people are going to have an opportunity to comment on the recommendations. So we'll look forward to the announcement for the when and how we can do that. Thanks again, Richard, as always. It's now time for our NASHBIT update, and we want to welcome Commissioner of Georgia, Kevin Tanner, for the State Department of Behavioral Health Developmental Disabilities. Are you there with us, Kevin?
Yeah, I'm here. Glad to be with you today.
Glad to be with you.
I appreciate that. Brian had asked me to update you on a project that we've undertaken here in Georgia we're real excited about, and that is our hashtag 86 the Stigma campaign. We recently did a poll here in Georgia, and we've discovered that only 16% of Georgians had heard of and actually knew what 988 was. And we know that's similar across the country. So one of the other things that we have found here in Georgia, according to the CDC, that we are having an unusually high number of restaurant workers die by overdose deaths, and that our suicide rate among work classes, restaurant workers are the highest, second only to construction workers. So we have worked together with the Giving Kitchen and the Restaurant Workers Association here in Georgia to create 86 The Stigma campaign. We're extremely excited about that. It rolled out at the first of this year. Our initial campaign kickoff is partnering with 40 participating restaurants and bars from Atlanta to Savannah. We reached over 2,500 food service workers in the first week, and we're reaching about 50,000 patrons a week through this campaign. It's also picked up regional, statewide, and national coverage, and we're estimating that it's reached as many as 60 million people now nationally on this campaign. The restaurant workers in the participating restaurants have shirts, and you can see on your screen there, they're wearing shirts that says 86 The Stigma. I think we all probably know that 86 is a term used in the restaurant industry to when we don't have something or we're going to get rid of something. 86 the cheese on my hamburger. So that's the lingo that workers in this industry understand very well. They also have hats, and the pens are using to take your orders are Sharpies that all have 988 and the 86 The Stigma logo on it. So this has been extremely popular among the Restaurant Association. The Restaurant Association here in Georgia has talked nationally with the National Association, and they're planning on picking this up as a national project going across the country. So this all actually started with a conversation that one of our employees had with someone at the Giving Kitchen here in Atlanta, talking about 988, talking about the people that they knew personally in the restaurant industry who had either committed suicide or attempted suicide. And this campaign was born out of that conversation. We brought in some outside partners to help us with design and logos. And so far, it's been extremely successful. So we're looking forward to continuing this. And we're also pulling one together for our construction workers here in Georgia as we continue to try to promote 988 across the state and get help to the people who need it. So happy, John, to answer any questions, but we're excited about this campaign and just wanted to share it with you.
Really appreciate that, Kevin. And I'll tell you that Georgia, as you know, has always been a leader in crisis care services as a state. And now it sounds like we're bucking to be a leader in promoting awareness of 988 services. So really appreciate the thought, the innovation, and the collaboration with community care and community resources and helping us reach people who are not traditionally reached, in this case, in the restaurant industry.
Thank you so much. And I'll just also mention that our First Lady here, Marty Kemp, in Georgia, has also recently came out with a series of videos, commercials that are running statewide now about 86 The Stigma and about 988. So we're running a major campaign here in Georgia about awareness, and we're looking forward to continuing to increase our call volume to 988 and continue to find ways to get people the help they need. So thanks for the partnership we have with this organization, and I look forward to continuing to work with you.
And Commissioner, we've noticed the success of those campaigns. We were just talking today. I have the privilege of working with Behavioral Health Link, which answers the Georgia Crisis and Access line. And we were just talking about the various spikes that happen different parts of the day. We said, oh, that must be when a commercial aired. And we were also looking at our answer rates, which are 99%. And this is because Georgia is taking care of the people who are taking care of Georgia residents. So thank you so much for that. Really appreciate it.
Thank you. Appreciate those kind words.
And let us turn now, if we can, to state updates. And we've got, I believe, Caitlin Davidson from Vibrant is going to start off. Caitlin?
Hi, thanks, John. So as we mentioned on our last update, many state legislative sessions are underway, and we're tracking a lot of bills related to 988 and the crisis continuum. So I'm going to highlight a few and then turn it over to my colleague from NAMI, Stephanie, to highlight some more. So recently we saw Nebraska introduce LB 929, which would require the state HHS agency to coordinate with the Public Service Commission to create coordination and codified coordination standards between 911 and 988, something that Richard mentioned is being looked at the national level, and also a topic that we saw in NASHBID's 2024 model bill updates, which were went over a few sessions ago. So we're tracking this one closely as we expect to see more states introduce 911, 988 coordination bills in the future. Additionally, on the awareness front, we're seeing last session, many states introduced or enacted legislation that would require student ID cards to include 988 as a resource on those cards. So we shared what some states are doing last update, but I did want to share that Maryland has actually had a bill, Senate Bill 122, recently passed through the Senate and is now in committee in the House. So we're seeing some quick movement on that. And now I'll turn it over to Stephanie to share a few more updates.
Yeah, thank you, Caitlin. Good to be with you folks. So I'll touch on another couple states. Starting in West Virginia, we do have West Virginia lit up in yellow with comprehensive legislation pending because a fee bill, HB 4900, has been reintroduced there. However, I do want to flag something about this bill. I spoke with some advocates on the ground there, and they shared that we're not really expecting this bill to move this session, given the overall political climate there, generally opposed to things resembling new fees, new taxes. So instead, the strategy for 2024 is going to be focusing energy on gaining an increase in state revenue funding for 988 call centers through the state budget. Also switching gears, I wanted to spotlight Washington State, which has many crisis care related bills already introduced early this session. And I'll just highlight a couple. There's Washington House Bill 2088, which would extend liability protections for crisis response workers. And then there's Senate Bill 5853, which would extend the state's 23-hour behavioral health crisis facility model to youth. So also helping to create crisis response centers for people under the age of 18. And I will also just quickly plug just a reminder that NAMI and our partners, we host monthly 988 state advocacy calls where you can hear from the folks in the states working on these bills across the country. Our next call is actually going to be this coming Monday, February 5th at 4 p.m. Eastern. If you're not yet signed up for those calls and you're interested in participating, all you need to do is shoot me an email and I will post my email in the chat.
Thank you so much, Stephanie and Caitlin. And I would imagine, Stephanie, that one of the reasons we're seeing so many bills coming out of Washington is they have a fee. And I hope that we're seeing a correlation between the number of states that have, or the states specifically that have passed a cell phone fee and the amount of legislation and therefore resources that are being allocated to crisis care. So again, really thank you for the updates and keeping an eye on the trends and needs in various states and some of the developments there that we need to be tracking on. If we could turn now to Angela Weeks, and Stephanie Hepburn is going to talk a little bit about the latest Crisis Talk article. Really interested to see what this article was about, Stephanie, and I'm anxious for you to talk about it and hear from Angela as well.
Thanks, John. So I'm excited to welcome Angela Weeks. She's the director of the University of Connecticut School of Social Work's National SOGI Center at Innovations Institute. Angela, you shared with me that while family support is key to reducing mental health risk for LGBTQ youth, there's no concerted effort across the U.S. to work with families. Can you share with us some of those risks and also how behavioral health providers can work with families to help mitigate them?
Yeah. And just thank you for having me and highlighting this topic as well. So there are pockets of really, really good work happening. There are people who have developed programs for families and are collecting data on that work and people advocating for it. But as far as a awareness and large effort nationally, it's lacking. So but we know what helps and we know what harms, right? So there's been data out for quite some time that shows the impact of family support and family rejection. And so we know that LGBTQ young people who are not supported by their families at all are 8 times more likely at risk of attempted suicide, 6 times more likely to have high levels of depression, and 3 times more likely to engage in harmful substance use and be at risk for things like HIV and STIs, compared to LGBTQ young people that are fully supported by their families. So it's not even compared to, we usually see data as in LGBTQ people compared to straight and cisgender people. In this case, the data is really alarming, even when comparing non-supportive versus very supportive. So, the more that we can work with families, the more that we can focus on prevention of crisis, prevention of negative health outcomes and life outcomes. We also know from Trevor Project reports and data that having just one supportive adult in an LGBTQ young person's life decreases the risk to suicide by 40%. So we know it helps. And even the smallest movements make a big difference. So usually families, they're on like a spectrum on their journey of support and acceptance, and they're thinking through a lot and they're processing a lot. Usually much of their concern and resistance to support the LGBTQ young person's identity is really rooted in fear of many different things, fear of their young person being bullied, fear of losing community, or fear of losing family. And so they're on a journey. But even if they can make small movements towards support and change behaviors little by little, it can make such a positive impact on the young person's well-being. So our goal is to increase that awareness and get behavioral health providers thinking about how they can do more outreach and support for families across the country.
Angela, when you mentioned some of these small movements, can you share with our audience what some of those might be that can make a really big difference in a young person's life?
Yeah, it could be things like letting the young person go to LGBTQ support groups, or connecting to other LGBTQ peers or mentors. It could be watching a show with LGBTQ people in it with the young person and talking about it. It could be allowing them to wear nail polish or try on different pronouns and different names that feel better for them. But it doesn't have to necessarily be overnight. The parent is now an advocate at the school, going to the pride parades. Even these little movements at home can have a really positive impact.
Thank you so much for joining us. Please look at the article and read it to see more about what Angela has to say. Thank you.
Thanks for having me.
Back to you, John.
Thanks, Stephanie. And really thanks to you, Angela. This is such an important topic. And again, I can't tell you how many kids I've known who the difference between whether they could or could not get through the day was whether or not their parents could support them as they were coming out. Really, really important. Thank you so much for that. As we talk about, we were talking earlier about the Crisis 3 Summit, and Amsterdam in June seems like it's far away, but it's not that far. And building a bridge between crisis services nationally to international perspectives is really going to be crucial for lessons learned as we build out the national crisis care guidelines for behavioral health. I wonder, Brian, since you're a co-sponsor of this event, Brian Hepburn, if you could talk a little bit about your perspective and NASHP's perspective on the importance of this event that's happening in June.
Yeah, thank you, John, and thank you for all the contributors to today's jam, another excellent jam. Thank you. The International Initiative on Mental Health Leadership has become the Global Leadership Exchange. And this meeting is in Amsterdam, and they have matches that go along with the meeting. And one of the matches is, as indicated, the Crisis Now 3. And it's really a nice opportunity to have the movement get international support, international input. And in the past, when we've had these Crisis Now meetings, they've really ended up with significant content being added that is helpful with the movement going forward. So I wanted to really give a shout out to David Covington and his leadership, especially in this next one. In addition, he has been involved in 1 and 2. And as we all know, he's been a leader in the movement, the crisis movement in the United States. So this is an opportunity for us to meet, to talk about where things are internationally, get support for the movement, and get content that will help us to move ahead in the United States, but will also provide content to our international partners so they can go back to their countries and move ahead. So thank you, John, and thank you to David for this work.
Thank you, Brian. We know the 2019's Crisis Summit had an influence on the creation of SAMHSA's national guidelines for behavioral health crisis care. And as they revamp them coming up, we can expect that this summit is also going to have an influence. Let's make sure that we're around for next week. The next 2 weeks are really going to be exciting for the Crisis Jam. I love what Franklin County is doing, and their crisis care center is state of the art. It's going to be world class, and let's hear about it from Jonathan Thomas and those folks. In the following week, we'll also be hearing from Jenna Baker, who's going to be talking about transforming crisis state and county partnerships. So thank you all so much for joining us this week, and we look forward to your joining us over the next couple of weeks when we can spread some more jam on your toast. Take care now.